Hello, everyone. Thank you for attending. We'll get going here in just a moment. All right. Thank you, everyone, for joining us for this webinar, Atrial Fibrillation. What is it and what can I do about it? Thanks for joining here on this afternoon, Tuesday afternoon with us with the UW Medicine Heart Institute. I am proud to present our two presenters who will be supporting this webinar today, Dr. Christine Chung, who is an assistant professor of medicine in the Division of Cardiology at UW School of Medicine. She is an interventional cardiologist specializing in the management of structural heart disease. She strives to provide patient-centered care, working together with patients and their families and other healthcare providers to fulfill their health-related goals. And her clinical interests include all forms of valvular heart disease and left atrial appendage occlusion, which she will be focusing on here today. And I am also presenting Dr. Nazem Akoum, Director of our Atrial Fibrillation Program, Director of Cardiac Electrophysiology Fellowship, and an Associate Professor of Medicine in the Division of Cardiology at UW Medicine. In addition to his vast experience in catheter ablation of atrial and ventricle arrhythmias, he is also an expert in cardiac pacemakers and defibrillators. Dr. Akoum conducts research aimed at matching patients with atrial fibrillation to the best treatment option. This personalized approach includes selecting the best candidates for catheter ablation and choosing the ablation approach, novel drugs, and devices to treat the arrhythmia and associated stroke risk. Thank you so much again for attending. And Dr. Akoum, please take it away.
Thank you so much, John Michael. Thank you, Christine, and also thanks everybody for joining us today. I will start sharing my screen. And in the first part of this presentation, I will focus on an overview of what atrial fibrillation is, how does it affect the heart, what are the consequences of atrial fibrillation, and what are our options in helping suppress it and avoid all of these complications that come with it.
And really quickly, just as a housekeeping item, if you do have questions throughout the presentation, please feel free to write those in the Q&A box. We will make sure at the end of the presentations to cover all of those questions.
Okay, so just a little bit of a anatomy lesson. So this is a cartoon of the heart that shows the 4 different chambers that the blood flows through as it goes through the heart and out into the circulation. And when we talk about atrial fibrillation, our focus is on the top chambers in the heart. So atria or atrial fibrillation. So the way the heart functions normally is in a very coordinated fashion between the electrical and the mechanical. So every single heartbeat starts with an electrical spark. There's an electrical system that is very highly regulated in the heart, and those electrical waves that are generated travel through that heart tissue. They're followed by the squeeze or the mechanical contraction. And as you can see, that electrical wave starts in the upper chamber and then it travels to the bottom, and this way the upper then the lower contract in sequence, and that's what helps keep that system running in a normal and regular fashion. When we substitute that normal electrical activation with atrial fibrillation, that smooth electrical signal that comes from our natural pacemaker and and the atria is replaced by a very chaotic electrical activation, as you could see here from all these arrows that are pointing in different directions. It's meant to illustrate that atrial fibrillation is a very chaotic electrical way of activating the heart. And as a consequence of that, the EKG, which is what you see here on the right side of the slide, demonstrates that the rhythm is no longer regular. It's actually on the faster side. And also, if you try to measure any kind of sequence or cadence to those beats, you will find that they're all over the place. So it's a very disorganized and irregular way of activating the heart. Now, if you have atrial fibrillation, you are not alone because it's a very common problem. So right now in 2022, it's estimated that over 5 million people have atrial fibrillation in the United States. And this number is expected to increase with time. And there are multiple reasons for that, including our population is generally getting older, and also we're doing a better job helping patients and people live longer, especially with chronic disease conditions where atrial fibrillation tends to keep company. So this is a growing problem, and makes it a very important one to think about and tackle and address. Now, when you have atrial fibrillation, you sometimes will hear different ways of describing atrial fibrillation, and that often refers to what pattern does your atrial fibrillation follow. So if you hear the word paroxysmal atrial fibrillation, what's meant by that is that atrial fibrillation comes and goes, and it does so on its own. So this is when you have bouts of atrial fibrillation or episodes that start and then they stop on their own without any intervention from your doctor. The second type, or the other pattern of atrial fibrillation that you also will sometimes hear about, is what's called persistent atrial fibrillation. And this is atrial fibrillation that doesn't stop on its own. So if you don't do anything about it, it tends to persist for at least a week at a time, and sometimes longer. And depending on how you're feeling and what your doctor thinks is the best way, you'll hear about different types of interventions to help break it or bring you out of it and back to normal rhythm. If that is left untreated and you stay in persistent atrial fibrillation for a long time, then it becomes harder to get out of that. And a lot of patients progress from that to what we call permanent atrial fibrillation. And this is sort of atrial fibrillation that we don't even try to get you out of anymore. So this is one that we basically accept that is going to be there for the long run. And we try to avoid getting to permanent atrial fibrillation, but sometimes, despite all of the treatment options, we can't get rid of the atrial fib, then we have to work around it and accept that it's going to be there for the long run. Now, what symptoms come with that diagnosis of atrial fibrillation? Most commonly, patients complain of shortness of breath. Sometimes they'll feel that racing heart or an irregularity in the heartbeat. Some people describe it as fluttering in the chest, or what sometimes is called palpitations. The feeling varies from one person to the other. So some experience butterflies is the way they describe it, or fish flip-flopping in the chest, or like horses are rumbling in there. So palpitations is a word that refers to all of these types of symptoms, just to describe that there's an awareness that something is different or abnormal with the heart rhythm. Other symptoms of atrial fibrillation can be dizziness or lightheadedness. Sometimes atrial fibrillation can make the heart go fast, and that's not a very efficient way for the heart to work. Sometimes the heart goes very slow when it's an atrial fibrillation. And that too can cause dizziness and can cause some people to feel that lightheaded feeling and sometimes even pass out. And another symptom or manifestation of atrial fibrillation could be overall decrease in energy or fatigue or inability to perform usual types of activities because of lack of energy. The atrial fibrillation takes that away, and we're tired all the time. There are also patients who actually don't feel any of these symptoms, and this tends to happen in patients who have had atrial fibrillation for a very long time, and especially if they're not very active and they can't tell when they're in atrial fibrillation and when they aren't, and that's because it's not really impacting their day-to-day activities very much. Now, why does it matter? In most patients, the consequences of atrial fibrillation is that it reduces the quality of life. Because of all of these symptoms that I mentioned, people don't feel well when they have atrial fibrillation. So one of the important goals when we're tackling atrial fibrillation is to try and improve that. How do we make our patients feel better? In addition to that, we also have two important worries when atrial fibrillation is diagnosed. The first worry is the risk that atrial fibrillation carries with it for a blood clot to develop in the heart, and consequently, blood clots that form in the heart can travel outside the heart, and if they go to the brain, for example, they might be a cause for a stroke. So that's an important worry and an important consequence of atrial fibrillation that we need to address. Other consequences of atrial fibrillation include heart failure, and this is when the overall pumping function of the heart starts going down because of the presence of atrial fibrillation. So restoring that normal rhythm to the heart sometimes helps restore the pumping function and avoid congestive heart failure development. What causes atrial fibrillation? Where does it come from? It's multifactorial, as you could see from this cartoon. So in most patients, there isn't a single factor that's responsible for their atrial fibrillation, but rather a combination of things. So atrial fibrillation is something that becomes more and more common as we get older. And the way I think about it is that atrial fibrillation is an arrhythmia that may be a manifestation of the wear and tear that affects the heart, just like wear and tear affects any other organs in our body. And that wear and tear creates the setup for that electrical abnormality to start and maintain itself. But there are other medical problems or diagnoses that also keep company with atrial fibrillation and are considered risk factors for it. And these include high blood pressure and other forms of heart disease like heart attacks and valve problems and congestive heart failure. There are also other factors like genetics or family history. If you have a first-degree family member that's also diagnosed with AFib, so first degree means a brother or a sister or a parent with atrial fibrillation, then the chances of you developing it are 4 times higher than somebody without that kind of family history. There are other things that are environmental or lifestyle related that contribute to atrial fibrillation, like excessive alcohol, excessive caffeine. Some people who do extreme sports like long distance running with marathons or cycling, that can also predispose to atrial fibrillation. So don't get me wrong, exercise is good, but in some patients, too much exercise can be the cause of developing atrial fibrillation. So when we diagnose atrial fibrillation, we kind of like to think of it globally, and we like to set plans after the diagnosis in order to manage not just the arrhythmia, but also the associated risk factors. So let's talk about what are our options to manage the arrhythmia itself. So you also may hear about different things and different words that I have put up here on the slide. So rate control, let's start with that. So rate control is something that all atrial fibrillation patients need to have. And what rate control means is that we want to make sure that atrial fibrillation is not causing the heart rate to be fast all the time. So we don't like the heart to be racing all the time, and we want to control the rate of the heart. So all AFib patients need rate control. We don't want to let the heart race because that can be a cause of heart failure and a lot of symptoms. So rate control is a common thing that all of our AFib patients will get. Rhythm control, on the other hand, is a step above rate control. So rhythm control is when we say, okay, we have controlled how fast the heart's going, and now we need to focus on getting the heart back to normal, regular activation. So this is going from atrial fibrillation back to normal rhythm. And this is accomplished by different options. There are ones that are short term, that are sort of quick fixes to help restore the heart rhythm. And then there are other options that are more long term. So rhythm control, when we want to convert the heart from AFib back to normal, can be done with an electrical shock. And this is what cardioversion means. So an electrical shock delivered to the heart after the patient receives some sedation and they fall asleep is a quick and effective way of putting the heart back to normal. But cardioversion, even though we use it a lot to help patients feel better on the short term, is not one that helps prevent atrial fibrillation from coming back. So if we want to think long-term in terms of helping the heart stay out of atrial fibrillation, if we want to prevent the next episode of atrial fibrillation, this is when we have to think about different options like medications or procedures like catheter ablation to help keep the heart in normal rhythm as a long-term strategy. So we'll talk more about these two in the coming slides. The other important pillar or part of the strategy in managing atrial fibrillation long-term is that comprehensive approach that includes managing the risk factors. So for patients who don't exercise enough, we want them to exercise, and if they are overweight, we want them to get back to as close to a normal weight as possible by eating healthy and avoiding also dietary triggers of atrial fibrillation like excessive alcohol or caffeine. We want to manage risk factors like diabetes and hypertension and sleep apnea. So all of these are considered modifiable risk factors and lifestyle changes that we will tell you about when we're managing atrial fib. So we also like to set goals, and I don't expect you to take notes or write down what every individual target on the slide is, but I want you to take home that we want to tackle all of these contributing factors to make sure that we're not just thinking about one particular strategy in managing the AFib, but also thinking about the triggers and the contributing factors as well. Now, this is a list of different medications that we sometimes use to maintain normal rhythm or achieve rhythm control in atrial fibrillation. These medications are what we call anti-AFib or anti-arrhythmic drugs. And as you can see, we have 6 options, and we choose these medications depending on what other contraindications or medical problems that each patient might have. So what may be safe for one patient may not be for another. And we tend to look at the big picture and choose which one is the best fit if we go the medication route. So this is a prescription that comes from a cardiologist, and the cardiologist or the arrhythmia specialist will choose efficacy and safety measures to choose which drug might be a good fit for every particular patient. Another option to try to keep patients out of atrial fibrillation is a procedure called catheter ablation. So compared to taking a pill, this is by definition a little bit more invasive. It involves catheters going through blood vessels and backwards up to the heart to target certain tissues in the heart that are responsible for initiating or maintaining the arrhythmia. So catheter ablation is one of the efficacious ways of dealing with atrial fibrillation, and I show you this slide to illustrate that point in particular, that whenever catheter ablation is compared to medications, it's been shown time and again that catheter ablation offers you a much higher chance of suppressing the AFib comparing that to antiarrhythmic drug treatment. This particular slide comes from a study that was sponsored by the National Institutes of Health. So your tax dollars and the government sponsored this study that compared these two treatment options and demonstrated clearly that the odds of staying out of atrial fibrillation are much, much better when patients are offered catheter ablation compared to when they're offered antiarrhythmic medications. Now, there are 2 general approaches to doing catheter ablation. Think of them as heating the tissue or freezing the tissue. So heating the tissue is most commonly accomplished by a technique called radiofrequency ablation. So radiofrequency is a special type of electricity that we run through our catheters, and that causes those catheters to warm up or heat up. And this is what's being illustrated here in this picture. So if that catheter is making contact with the tissue in the heart, and we run that electricity through it, it causes a small burn where the catheter is touching. And we target those burns to those areas that are causing the atrial fibrillation. The other way to achieve that is with another technique that uses freezing as the approach. So this is what you sometimes will hear referred to as cryo balloon ablation. Cryo means freezing. Balloon is just the shape of the catheter as we deploy it in the heart and target that tissue. Both techniques work really well, and they're almost equally efficacious. And a couple of more studies have also addressed in comparison to antiarrhythmic drugs using the freezing technique, and showed also that it's superior to the drug therapy, especially when it's offered to patients early after they get diagnosed with their arrhythmia. So does that mean that ablation is the way to go for everybody and we should offer it across the board and everybody's a good candidate? The answer is no. And that another way of saying this is that ablation doesn't work the same way in all our patients. So there are patients where ablation works very well in, and there are others that don't respond to it very well and they continue to have atrial fibrillation. So how do we choose the right candidates for ablation? We look at several factors, and that includes how long patients have had atrial fibrillation, what sort of company does it keep in terms of other forms of heart disease on the valves or heart failure. And we also like to get more specific and personal in terms of understanding every person's atrial fibrillation. So we try to study the heart as much as possible before we decide on whether ablation is a good idea. So what I'm showing you here is an approach that we take at the University of Washington that uses advanced cardiac imaging. And we particularly use MRI scanning of the heart to gain more knowledge and information about the changes that are happening in the heart in every patient. So once we do this MRI imaging, we're able then to do a three-dimensional model of every person's atria and understand what it looks like, how big it is. It kind of gives us a roadmap of what we, of that chamber that we need to be working in. And it also tells us about how much scar tissue there is on that atrium. Because what our studies have shown us is that the more scar tissue we have in the tissue of the heart, the more scar tissue all of these risk factors have created, the less successful we are in terms of our ablation. So we like to get this information ahead of time, and we like to see what we're up against, because when we grouped our patients based on how diseased or how fibrotic their atria are, we've been able to group our patients in terms of their response to this ablation therapy. So patients with more advanced forms of the disease, more fibrotic tissue, don't do as well when we take them to the lab and do our ablation procedures. So this is very useful information when we're having our conversation with you about whether ablation is actually the right choice for you or not. So it's as personal as it gets in terms of understanding your own AFib and deciding whether to embark on this road to ablation or not. So to summarize, as far as treating the atrial fibrillation itself and maintaining normal rhythm, comparing it to antiarrhythmic drugs, ablation is much more effective in helping you stay out of atrial fibrillation. It helps improve the quality of life by suppressing the AFib. It helps reduce hospitalizations and ER visits that result from that. Those studies and our expertise have gotten us to a point where ablation is actually very safe. The risk of complications with catheter ablation in experienced centers like ours that do a lot of procedures and has the expertise, the rate of complication is very low. And in addition to that, keeping you out of atrial fibrillation helps restore the longevity. It helps reduce cardiovascular mortality in patients with heart failure, and also new data is suggesting that it also helps reduce the risk of stroke, which is another one of the complications of atrial fib. I'll also mention one other thing, and I get asked this question a lot, so that's why I put up this slide, is do patients with atrial fibrillation need pacemakers? And some of them do. So patients with atrial fibrillation as a group have a higher chance of needing to have a pacemaker compared to other patients of the same age that don't have AFib. And the reason for that is those structural changes that I showed, that wear and tear, that fibrotic, that scar tissue that develops in the heart, sometimes can also impact the heart's natural pacemaker. So that pacemaker tends to beat slower in patients with atrial fibrillation. And sometimes we actually see the heart kind of swing from one side of the spectrum to the other, and it can go fast sometimes, and it can go slow some other times, and it can alternate between those two. So as you can see from this picture here that I'm pointing to with my mouse, the heart's going fast on the left side here, then all of a sudden it pauses, and you have a few seconds with no heart beating, and then it comes out a little bit slow. So these alternations in fast and slow sometimes can cause people to feel dizzy and sometimes pass out. And this is where a pacemaker can be very, very helpful in avoiding these kinds of pauses. So patients with atrial fibrillation sometimes do need pacemakers, and in addition to the other options that we talked about to manage their arrhythmia. So the next part of the talk will focus on what are our options as far as managing and reducing the risk of stroke that comes with atrial fibrillation. And I'm happy to hand over this part of the presentation to Dr. Chung. And we'll come back later and sort of wrap up and hopefully take your questions and go from there.
Wonderful. All right, so I am just going to share my screen.
Hi, Dr. Chung.
Hi, Teresa. I'm so glad you could join. I am just going to jump into the educational portion, and then hopefully we can loop back to you in about 10 minutes or so.
Well, I only have about 5 minutes, 10 minutes. I have to check in at 12:40.
Oh, okay. So Teresa is one of my patients that I was fortunate to meet in the clinic and take care of about a year ago. And she was kind enough to join us. She's actually en route to an appointment. And so we're going a little bit out of order, but since we have her here with us, why don't we actually have Teresa, sort of participate and share her story, and then we'll let her go so that she can make it to her appointment on time. So Teresa, you have a pretty unique to you reason for why you were seeking a non-medication based alternative for stroke prevention for your atrial fibrillation. I was wondering if you'd be willing to share a little bit about your reasons for getting interested in that procedure.
Yes, in 2018, in October, I started experiencing AFib, but I thought I had a pulmonary problem, but it wasn't. It was AFib. And then in that October, I had a stroke when I was on vacation. So as a result of that, they gave me TPA, and that brought me back, but my cardiologist put me on a blood thinner. Then my husband had a massive, devastating stroke, November of 2020. When he had that stroke, he was on a blood thinner from another surgery earlier in the year, and because of that, they couldn't give him TPA. So I became the caregiver for the most part in all the decisions that had to be made. So as a result, I had a couple of different outbreaks of AFib, and I had a couple of ablations that worked very well. The second one especially, it kind of cleared everything up. But the reason I wanted to have the Watchman procedure was to be able to get off of blood thinners. Getting off of blood thinners gives me the opportunity, should I have another stroke, to be able to be given TPA, because I was in the hospital within 45 minutes of my stroke starting. They gave me that drug, and I came back out and I finished my vacation. I was in ICU for one night only, 24 hours, and then in a step down neurology unit, and I was out the door in a total of 2 days. So because of Monty's condition and how severe his stroke was and how we're still dealing with the aftermath, I need to be able to be free from AFib forever, and if possible, to never have an opportunity for another stroke. So I wanted to get the Watchman procedure. Then I was on Plavix for a little while, taken off of Eliquis, and now I am off everything except a baby aspirin. And the appointment I'm going to right now is a cardiologist pre-op because I need my knee replaced. So they're going to want to put me on another blood thinner. I hope not after surgery, but this is why I had it done. So I could be able to take care of Monty, and should I have another stroke, I would be able to, get TPA and be off blood thinners. So the Watchman procedure was a wonderful thing. And I also had my husband go in for the Watchman procedure. Christine did a great job. I've had no problems since, nor has Monty. Thanks, Christine.
Thank you so much for sharing your story. And while we have you for another couple minutes, I was just wondering, would you be willing to share with us what the experience was like? How it felt sort of going through the process?
I think the most uncomfortable thing that I experienced was the TEE, because a student did it, and the nurse didn't give me enough sedation or whatever you call it. But other than that, going in for a couple of different appointments for things like that, that was fine. You just have to do things like that to make sure that we're getting it all done right. But the procedure itself, it was painless. I don't remember any of it. I woke up and I had this new little thing inside, and it was starting to work, and I was thrilled, and I was waiting for my 6 months to pass to get off blood thinners.
Well, Teresa, thank you so much for your time. I know that you squeezed us into a really hectic schedule, so I appreciate you joining us.
You're so welcome.
Thank you.
Tell people about you all the time. I give them the Watchman procedure link so they can see, because a lot of them have had strokes as well, and they're about, so anyway, I share that information. I hope it grows your business as well as your personal enjoyment, and I hope your little baby is doing great. So I'll see you later.
Thank
Dr.
you so
Christine.
much.
Okay,
Yeah,
hon.
thanks for joining us.
You bet. Take care.
Thank you. So just a quick, note of clarification there for our participants. The nature of the conversation and shared decision-making process that Teresa and I went through was very unique and particular to her situation. And I just want to, again, clarify that not every patient who comes in with a stroke is going to be a candidate for TPA just because they're off of a blood thinner. And that was something that, Teresa and I spent a lot of time clarifying, but it was something that was personally very important to her. So just to dive into the rest of our educational component here. So Dr. Akoum did a really fabulous job just, giving a lay of the land of how complex atrial fibrillation is as a disease entity, and all the many, many things that, your doctors are thinking about when you come in with a new diagnosis, and all the different, risk factors, symptoms, and the different types of medications, as well as therapies, interventional therapies that we think about when trying to best treat patients. Doing everything we can to minimize long-term complications as well as improve quality of life. So my focus in the next few minutes is going to be relatively narrow. I am just going to focus on the relationship between atrial fibrillation and the risk of stroke, and then what the options are for managing that over the course of a patient's lifetime. So as Dr. Akoum mentioned earlier, atrial fibrillation increases the risk of blood clots forming inside the heart, and that is a potential source of stroke. And then additionally, the presence of this irregular rhythm, as well as the fast heart rates that can sometimes accompany it, can set people up for heart failure. This is just a table showing how, as people live longer with atrial fibrillation, the risk of associated complications like stroke and heart failure continue to increase over time. And these percentages for the annual risk of stroke are, in people who are not receiving a targeted therapy for it. So these would be the rates of stroke seen if somebody was not on any treatment. So going back to how atrial fibrillation actually can result in a stroke, there is a outpouching of the left upper chamber of the heart called the left atrial appendage. It's sort of like our appendix in the sense that we all have one, but its sort of specific function and role in the body is not totally well understood. But because it hangs off the main chamber and often has a lot of folds, sort of nooks and crannies, combined with some of the slow blood flow that can happen in the left upper chamber in patients with an irregular heart rhythm, this can sort of set up a perfect environment for stagnant blood that pools and eventually forms clots in this part of the heart called the left atrial appendage. It's thought that the majority of stroke-causing clots that originated in the heart in a patient with atrial fibrillation who ends up with a stroke come from this particular chamber or area of the heart. So, going back to the sort of broad categories of treatment considerations when someone comes in with a diagnosis of atrial fibrillation, Dr. Akoum covered extensively the ways that we can control the underlying arrhythmia and how we can try to improve symptoms and quality of life by addressing the heart rate as well as the rhythm. In the next few minutes, we'll focus on the options that we have for managing the stroke risk over the lifetime of a patient living with a diagnosis of atrial fibrillation. So it is still the standard of care and pretty much the default therapy up front for someone with a new diagnosis of atrial fibrillation to be put on an oral blood thinner. There are some cases in which a patient will be treated alternatively with antiplatelet medications, but those two groups of meds kind of fall under the umbrella of medical therapy for stroke risk. More recently, there's been development and sort of increasing adoption of a non-medication based interventional approach called left atrial appendage closure. This is a procedure that happens to be an area of overlap between the arrhythmia specialist like Dr. Akoum and then the interventional cardiologist like myself. So it's a procedure performed by doctors from both specialties. And as Dr. Akoum mentioned, all of our therapeutic considerations for an individual patient are very much personalized. So there's no sort of one size fits all approach. When we are considering with an individual patient what's the best way of minimizing stroke risk, we have to take into account the fact that all of these medications that help prevent clots from forming, whether it's platelet targeted or protein targeted, they all come at the cost of increased risk of bleeding. It's sort of two sides of the same coin. And so when your doctor is making a recommendation to you about how to proceed, we are keeping in the back of our minds how to balance the risk of a stroke with the potential risk of a serious bleed. And we have lots of data based on large population-based studies that in people who have a diagnosis of AFib are considered to have an increased risk of stroke and then are prescribed by their doctor some sort of a blood thinner. The long-term consistent use of these blood thinners tends to not be great. So for instance, observational studies of tens of thousands of patients have shown that over the next few years, as somebody is prescribed a blood thinner, about 70% of people will be able to consistently take it every single day. And in order to really get the maximum benefit of stroke prevention from one of these medications, you would need to take it consistently, because often it's in those gaps where blood thinner use is interrupted briefly that people can actually be in somewhat of a hyperclotting state, and there might be higher risk of clotting complications in those periods where blood thinners are stopping and starting. And particularly because the risk of stroke, as well as the risk of experiencing a bleeding complication, tend to increase with advancing age, there really was a clinical need to develop an alternative therapy, because we know that many people, one, are not good candidates for long-term blood thinner use. And then number two, many people have trouble taking it consistently over years and years. And then three, increasingly, there are people with a lot of various personal sort of social, psychosocial type of considerations. For instance, people who have trouble affording expensive copays for their blood thinners, as well as reasons like the one that Teresa mentioned for wanting to stop their blood thinner in the long term. So this non-medication based procedure alternative is called left atrial appendage closure. It basically functions like a cork or a plug, a stopper, to block off the opening of the appendage and prevent any clots that form in that part of the heart from escaping out into the rest of the circulation. This therapy is not novel. It's been around for over a decade. There were large clinical trials that were conducted in the early 2010s, leading up to its FDA approval for commercial use. And those studies proved that the procedure is as effective as Coumadin at preventing strokes and other clot-related complications, and has the benefit over the long run of reduced risk of bleeding. There are smaller trials as well, and currently ongoing clinical trials comparing this procedure to the newer blood thinners. So that would be things like rivaroxaban or Xarelto, apixaban or Eliquis, demonstrating that there's an early signal demonstrating that the procedure is equivalent to those newer medications as well. Just to quickly walk through some of the details of the procedure, it is not open heart surgery. It's a minimally invasive procedure, similar to ablation done through a vein in the groin. We do perform it under general anesthesia so that the camera, the ultrasound probe that goes down the throat, is easier to tolerate. As you heard Teresa say earlier, part of the one of the most uncomfortable aspects of this is just having that ultrasound probe down the throat. So to take that piece off the table, we put everyone to sleep. Procedure is pretty quick. It takes around 1 hour. And then most of the time we're keeping patients overnight for monitoring in the hospital, but there are options for same-day discharge, which we have safely done. In terms of the post-procedure follow-up, there is a discussion beforehand about what kinds of blood thinners and medications will continue in the first few weeks after the device goes in, to make sure that there are no clots that form on the surface of the device while the body is healing it and depositing a new layer of tissue. At around 6 weeks, everyone gets a device check with a transesophageal echo. That's the mini camera that goes down the throat. The vast majority of times the device looks great. There's no residual leaking around it. There's no clots on the surface of the device. And then we're able to give people the good news that they can stop their blood thinner permanently. So in order to know, similar to ablation versus medical therapy, in order to know whether this procedure may be a suitable alternative to being on a blood thinner for you, it's important to have a conversation with your doctors. And then also Dr. Akoum and I would be happy to walk you through that conversation as well. There are a few pretty rare cases in which the procedure may not be suitable. So certainly anyone with a known allergy to nitinol, just because that's a significant component of the device. And then there are a few instances where someone's anatomy may not be suitable for the commercially available devices. In addition to the Watchman, recently there was FDA approval of a second device called the Amulet, which is actually very commonly used in places outside the US, like in Europe. And we are very excited to be bringing it to UW soon. And I think in general, more devices just increases the number of patients that we're able to treat. And then anyone who requires long-term use of a blood thinner for a condition other than atrial fibrillation really may not benefit from this procedure, because one of the main purposes of it is to get people off their blood thinner. The procedure is widely covered by a lot of commercial insurance providers, and then is certainly covered by Medicare. There are several resources out there for those of you that may want to do a deep dive into some of the original data, looking at the original clinical trials. So the Heart Rhythm Society is a professional society for the arrhythmia doctors. And then the American Heart Association is sort of the broader professional society for all of the cardiologists. And then, as Teresa mentioned, the Watchman website, so this is, a commercial website by the company that makes the device, but I throw it up there because they do have some really great brief tutorials that are great at sort of breaking down some of the information around AFib, blood thinners, and the procedure. So with that, I'm going to hand things back over to Dr. Akoum to wrap up this session, and we want to make sure that we leave plenty of time at the end to field questions from the participants.
Thank you so much. Gonna switch screens on you again. Just to quickly wrap things up. So some practical questions. When should you see one of us or an AFib specialist, or come to the arrhythmia clinic to talk about your options to manage the arrhythmia and also associated stroke risk? You can see us anytime, even if you have had AFib for a long time, even if it's the first time. We want, the sooner you see us, the better. We want to understand where things are at with you and have a conversation about what's the best way forward. In general, however, the sooner we're able to see you after your diagnosis, the better. That helps us intervene on the risk factors, and we talk about these various therapies where our chances of success will be much better. So that makes us happy that we're able to make a difference in your medical problem, and it also yields better results as far as being able to get ahead of things and take care of your AFib and all of its associated problems. We also want to engage with your other doctors, whether they're cardiologists or primary care providers, and we want to engage with you. So we want this to be a collaborative approach, and everybody plays their part. As far as where can we see each other within the UW system, we have specialists that have clinics and practice at the various locations of our campus. So in the pictures you see here is the main campus, or UW Medical Center Montlake. We also have cardiology clinics and arrhythmia clinics at Harborview Medical Center, Northwest Hospital campus, and also for our veterans, we also have the VA, and we have cardiologists and arrhythmia specialists there as well. So that was it. That's our wrap up. This is also some web resources and internet links for you to look us up and find our providers and our locations. And I will keep this up as we go to John Michael, and hopefully we'll be going through some of your questions.
Thank you both so much. Always very informative. And if you do have any questions, again, this resource is that if you do want to see either Dr. Akoum, Dr. Chung, or any of our team in the electrophysiology section, or specifically for the left atrial appendage closure, you can click on uwmedicine.org/heart, click make an appointment, and you'll be directed to a self-referral that you can then create an appointment with any of our providers. If you do have a process of doing that within eCare or any of your tools that you have currently, you can also go towards that methodology. To get started with questions, I think one of the more general questions that was asked is there a cure for atrial fibrillation other than taking meds?
So I can take a stab at that one. So yes, and hopefully with the options that I discussed, especially the catheter ablation option, we can get as close to a cure as possible. So definitely is superior to taking antiarrhythmic drugs. It offers you a much better chance of not having atrial fibrillation. It's a therapy that is safe. It's also minimally invasive with catheters. Lots of times patients go home the same day. Sometimes we keep you overnight for observation. But at the same time, not everybody responds to ablation and stops having AFib altogether. Sometimes we can achieve that, and we have a good chance at that. Some other times we have to combine treatments. So sometimes we have to do the procedure more than once to get the result that we want. Sometimes we have to do ablation and use the medications to get to the result that we want. So going back to being personalized and use as much of the precise techniques and matching the patient to the therapy, we want to work with you on a plan. And if it's ablation, great. If it does the job, sometimes it's a combination of things like risk factor modification, ablation, and drugs to get us to where we want to be. But you have all of these options available to you.
Great. And is there a device a person may use to detect AFib any better than another?
So the diagnosis of AFib is made through an electrical recording of the heart. So that can be done in the office when you get an EKG, for example, or it can be done with a monitor that your doctor might prescribe. And monitors are also stickers with electrical wires that record that electrical information when you're not in the clinic. So it records for a longer period of time. And it can be very helpful for changes in the rhythm that may be coming and going, or something that may be episodic, like AFib can be. In this day and age, we also have a lot of new ways of monitoring and detecting atrial fibrillation, including data that comes from wearable devices. So there are different options of wearable devices out there on the market, from watches to rings to ECG straps that might come from your exercise equipment. So these use sometimes a pulse measurement approach to diagnose atrial fibrillation. So your watch, for example, or some of the other wearable technologies can detect your pulse and can check for you if it's a fast pulse or if it's an irregular pulse. So it can alert you for the presence of any of these two things. Some of them also have the capability of recording EKG. So for example, newer models of Apple Watches can record EKG in addition to recording pulse. There are other gadgets out there that record EKG that you can share with us. And if they're good quality, they can be as diagnostic as the EKG that we get in clinic, or as the ones we get from a hospital issued heart monitor. So in our clinic, we use data from all of these sources. So we have patients that we give them hospital monitors, and we have patients that share their data from their wearable devices with us through their charts, and we can use that information as well.
Great. In terms of weight and size, with being overweight, some people may have heard some scary things about working out with AFib. What are thoughts on doing that?
So don't let AFib stop you from exercising. I don't want to leave you with that message at all. So AFib might cause you to feel more tired or more short of breath, but when you work on it with your doctor and you explore all of these treatment options to help you control the symptoms and feel better, we actually do want to get you back to exercising and having and being active and having a normal routine and a normal life. So you might feel like your ability to exercise may be compromised with AFib symptoms, but work with us and we'll want to get you back to your normal exercise routine or getting back to being more active, because that on the long run also helps you and helps us control the AFib.
Another question here, how long is an ablation expected to last? Why would someone in AFib need a pacemaker and an ablation to get into sinus rhythm?
So sometimes when we run into the scenario of the AFib causing the heart to race and then all of a sudden causing the heart to be too slow, we're limited in what medications we can use, because the medications that we use to slow down the heart can help us with the AFib when it's going fast, but they can create a new problem for us when these pauses are happening because they make them worse. So in patients who alternate between fast and slow, sometimes we just have to use a pacemaker to cover the slow part of things, so we can use our medications or our ablation procedures to take care of the fast. So some of our AFib patients need to have both. Sometimes when we suppress the AFib, especially with ablation, and we remove this fast alternating with slow because we've restored the heart back to its normal rhythm and it kind of stays there, you can avoid needing a pacemaker if we're successful in suppressing the AFib.
And now getting a little bit into the anticoagulations, are there any danger of warfarin and bones?
Yeah, so I actually just did a quick literature search on this because I did not know the answer off the top of my head. And it does say that long-term warfarin use can lead to decreased bone mineral density and can be a risk factor for osteoporosis. It's less clear. There isn't a ton of data yet on whether that risk is the same, better, or worse for the newer blood thinners like the rivaroxaban and the pixabans. So that it seems like the data for that is less clear.
And then in terms of doing well on Coumadin, is there any reason to change or do anything differently?
So again, I think that is a very personalized, requires a very personalized approach. I did recently treat an 80-something-year-old woman in the clinic who had been on Coumadin without any bleeding problems for many years, but she felt that as she was getting older, her gait was getting a little less steady. And she just had a fear that at some point in the future, she could have a fall and what the implication of being on a blood thinner at that time might be. I thought that was a very reasonable concern. And so, after undergoing a detailed conversation and sort of undergoing that shared decision-making process, we went ahead and proceeded with left atrial appendage closure.
And in terms of ablations and just the question around why someone would still be on warfarin, if someone's had 2 ablations, why would someone still be on anticoagulation? I know we've talked a little bit about this, but just what those reasons may be to still be on an anticoag.
That is a fantastic question, and it's usually one of the important conversations that we have when we're thinking about managing AFib and its associated risks. So when we are able to suppress the AFib and we do an ablation, let's say, and we can't detect it anymore, and we're going through follow-up, a common question is, if I'm not having AFib, why am I still at risk for a stroke, and why should I take a blood thinner? And it's a very, very good question, and we ask it ourselves also. Hypothetically, and some data is starting to come out that suggests that if we successfully suppress the AFib, we are actually also reducing the risk of stroke. So that makes a strong argument that maybe we need to reevaluate this decision to keep people on anticoagulants. What is still unknown is if catheter ablation that suppresses AFib reduces the risk of stroke, does it reduce it enough to completely take away the risk of stroke and therefore make it safe to stop the blood thinner? And until we have the answer to that question, most of us, because stroke is such a devastating problem, will err on the side of being conservative and keeping the blood thinner on board, just because we want to extend as much as possible the period after an ablation where we want to be sure that there's going to be any more AFib. But sort of bringing it to, down to the individual patient level, this is a conversation that we will have with every patient who asks this question, and we'll look at how the procedure went, we'll look at other risk factors, and we'll look at sort of the overall risk of stroke and the overall risk of bleeding with blood thinners, and decide together whether we want to keep the blood thinner on board or not. Another option that is also coming up in conversation that we are also offering to patients increasingly frequently is trying to combine therapies together. So as we mentioned, in terms of treatment options, we've talked about ablation as something that we go through the veins and we go backwards and we go up to the heart, and we have our catheters in the left atrium trying to deliver our ablation. It's essentially the same route that we take when we deploy the left atrial appendage occlusion devices. So why not take care of both at the same time? Since we're using the same veins, we're taking the same route, we're going back to the heart. So for me, it makes a lot of sense. For a lot of patients also, especially if they have bleeding concerns from being on blood thinners, we've offered this combined approach and it's worked pretty well. There are currently ongoing studies that are studying this in a systematic fashion to see if combination therapy of ablation and left atrial appendage occlusion is going to help us on the long run. So reduce the risk of stroke and help patients deal with their AFib.
Great. All great answers. We are up at time at 1 o'clock here. Wrap things up. If you do have any additional questions, please reach out. I just put the email up in the chat box, uwheart@uw.edu. We'll be sure to try and answer those questions here as soon as we can. And if you do have any specific questions about your condition or ways that we might help, again, if you would like to reach out to your current cardiologist or be able to submit a self-referral, we can help expedite the process to have a consult for whatever is happening in your situation. But thank you again for attending. Thank you, Dr. Christine Chung, Dr. Nazem Akoum. I really appreciate your time. Look forward to seeing you again soon. Thank you, everybody.
Thank you.
Thank you so much.